Dr. Murray is, but I think just to keep to time, we will just start. Thank you.
Thank you very much, David. Ladies and gentlemen, I'm happy to present the 2 years results of the Syntex trial. As you may remember that last year during the EX meeting, the first year results were presented by Fred Moore and Patrick Sorais, and now it's time to come to look at the 2 years outcome of the Syntex trial. And of course we will go on looking at these results up until 5 years, so that will be the second major outcome of this trial. But of course it is interesting to see how the patients are doing at 2 years. Just to remind you a little bit of why the Syntex trial was performed. Well, we all know that there were technical advances in PCI. With the drug-eluting stents, it was clear that the restenosis rate was going down. But on the other hand, surgery had also improved. There was more off-pump surgery, more arterial revascularization, but what is also important is that the perioperative care had improved. So we said you cannot compare the drug-eluting stents from nowadays results with the results of surgery from, let's say, 5 years or 8 years ago. So if you want to have a clear understanding what the role is of drug-eluting stents, you should run another trial comparing PCI with coronary surgery. So the Syntex trial design was that the heart team was very crucial in looking at which patients could be randomized. So we had 62 European sites and 23 American sites. There were only de novo 3-vessel disease patients and left main disease patients. So really the high-risk patient population. There were only limited exclusion criteria. Patients that came in with acute myocardial infarction, for example, were excluded from randomization. And what was very important is that the surgeon and the cardiologist had to look at the angiogram and then decide whether the patient could be randomized. If the patient could not be randomized because the cardiologist thought that it was too difficult to do a PCI procedure in this patient, the patient was sent to the CABG registry. If the surgeon, on the other hand, said, well, this patient is too high risk for surgery, it might better have PCI, although the angiogram shows that actually CABG might be the preferred option, this patient was sent to the PCI registry. These patients are, for example, patients with bad renal function, with malignant diseases, with calcified aorta, so high-risk patients for surgery. So at the end, we want to randomize 1,800 patients, and after the study, we had 1,275 patients in the registries. Patients were stratified for left main disease and diabetes. Now, one of the new elements of the Syntex trial was the so-called Syntex score. And like I just said, the surgeon and the cardiologist had to look very carefully at the angiogram to really try to find out whether this patient could be randomized. And actually, to try to force them to look very carefully, we developed the Syntex score. Syntex score will score whether there were the number of lesions that were involved, whether it was a left main or 3-vessel disease, whether a total occlusion was involved, tortuosity of the vessel, bifurcation, thrombus, calcification, and the dominance, whether it was left or right dominant, the coronary system. The higher the Syntex score, the more complex, the lower the Syntex score, the easier the coronary lesions are. If you want to look up this Syntex score in more detail, and if you want to try to use the Syntex score in your own site, we now have a website called thesyntexscore.com where there is the calculator, and you can even download it to your own computer. So 1,800 patients were enrolled. 897 patients for surgery, 903 for PCI. At 1 year follow-up, we had 849 patients to evaluate in surgery and 891 patients for PCI. Now at the 2 years, we have 836 patients in surgery and 885 for the PCI population. And you see we lost some patients during follow-up, and that's mainly because some patients withdrew their consent. Of course, this is actually a slide just to reassure you that the randomization worked. Age is the same in the PCI in Texas PCI population versus the CABG population, and also the other scores don't really differ between the two populations. Something you would expect if you randomize the population well. So if we just think back of the 1 year results of Syntax, we saw that the safety endpoints, there was no significant difference, 7.6% versus 7.5% for deaths, CVA, and myocardial infarction. If we just look at the strokes, we know that in surgery already the stroke rate is always a little bit higher. And that was also the case in Syntax, was 2.2% for surgery and 0.6% for PCI. And Michael Mack will, in his presentation, address the topic of strokes after surgery. Then, of course, as we know from previous trials, surgery was always better in terms of repeat revascularization. And you see that the rate of repeat revascularization is much lower in surgery compared to PCI. Now, the primary endpoint was MACE, so that means a combination of the safety endpoint and the repeat revascularization endpoint. Thanks. So here you see then that the MACE rate is lower in surgery compared to PCI, and it's still, that was very significant. So PCI did not meet the primary endpoint, and it proved not to be non-inferior. So surgery was actually superior to PCI. So if we now look at the 2 years results, well, let's first take a look at the mortality, which is actually the hardest endpoint. In the first year, it was 3.5% versus 4.4, and in the second year, it was 1.5 versus 1.9. And you see the total results is 6.2 versus 4.9. So a little bit higher in PCI, but not significantly higher. If we look at the CVA rate, you see that the difference is 2.8 versus 1.4, and it's still significant at 2 years. But most probably at 3 years or 5 years, it will not be longer significant. The myocardial infarction rate is now higher in PCI. At 1 year you saw it was 3.3% versus 4.8, and after 1 year you see more myocardial infarction occurring in the PCI population. That means that now we have a difference of 5.9 versus 3.3% in surgery, higher myocardial infarction rate for PCI. But if we combine the safety endpoints, again, mortality, CVA, and myocardial infarction, there is not a real significant difference between the two populations. It's 10.8 versus 9.6%. Now, again, the repeat revascularization, and actually surgery always proved to be superior, and that was also the case at the 2 years. At 1 year it was 5.9 versus 13.5%, and at 1 year, it's 3.7 versus 5.6%. Total, 17.4 versus 8.6. So surgery is still superior at 2 years. Now, when we combine these two, and remember this was actually the primary endpoint was MACE at 1 year, and now if we look at MACE at 2 years, there's still a difference between PCI and coronary surgery, 23.4% versus 16.3. So again, surgery with a better outcome. But now we want to take a closer look, actually, because the Syntax score we thought could be a major predictor here. If you have patients with a low Syntax score, so the easier patients with less extensive coronary artery disease, you see that actually there's not a difference between the PCI and the coronary bypass surgery population. The two curves cross a little bit here, but it's 19.4 versus 17.4. So no difference between the two. Now, if we look at the intermediate score, so a little bit more complex patients, you'll see that there's also not a significant difference yet, but it's 22.8% versus 16.4%. So there seems to be a trend that in the intermediate score, surgery tends to do a little bit better than PCI. But the marked difference is in the highest Syntax score population. Here you see that in PCI it's 28.2% versus 15.4% for surgery. So the more complex the patients are, the better the results with surgery. And actually, if you look at the outcome of surgery across the 3 tertiles, it seems that surgery is more or less immune, you could say, for the Syntax score. We have the same results in the low Syntax score population versus the high Syntax score population. But PCI is doing worse the higher the Syntax score gets. Now it's interesting to look at another subgroup the three vessel disease versus the left main disease patients. Here the three vessel disease patients, this is surgery is the blue bar and the yellow bar is PCI. Safety endpoint, no significant difference, but again in repeat revascularization surgery is doing better, and in the MACE population surgery is also doing better. But now actually quite striking finding was the fact that if you look at the left main disease patients, there's no significant difference in the safety endpoints here. And there is a little bit difference here in the repeat revascularization, surgery is doing better. But if we look at the MACE at the endpoint here, you see that surgery is lower than PCI, but it's not significantly different. But now we have to keep in mind that there are only 705 patients who had left main disease. So while the total trial was 1,800 patients, this group already contains 705 patients. So we have to be careful with interpreting these data and really saying, well, left main disease can be treated with PCI is actually quite dangerous to conclude that from this trial. Now, of course, it's interesting also to look at the different endpoints. This is the low syntax score population again. If we look at death and CVA and myocardial infarction, you see there's actually also no difference in the different components except for repeat revascularization where surgery is doing better. Now if we look at the intermediate score patients, so again the more complex patients, you see that for the different components only myocardial infarction is lower in surgery, repeat revascularization is lower in surgery, and the MACE is almost significant. But if we look at the highest syntax score patient, there is where the difference is quite significant. If you look at the hardest endpoint, which is mortality, you see that there's really a marked difference between the PCI and surgery population. It's 3.3% with surgery versus 9.4% with PCI, which is highly significant. So about 3 times higher mortality for PCI. So this is a very, very important message here. Because if you now after your discussion in your heart team with the cardiologist and the surgeon, you can say if the patient with a high syntax score is not only repeat revascularization, it's not that the patient just comes back for another PCI procedure, but the mortality is really higher. Now again, let's look at the registries. And we think that the registries have not actually get enough attention yet. And we should stress the fact that a lot of the patients could not be randomized because they were too complex for PCI. Still, if we look at the outcome of surgery, it is very good. It's 12.9% MACE at 2 years. So that means these were the patients that were so complex that they would not be treated with PCI or could not be treated with PCI, and the cardiologist put a signature on the form that this patient had to send to the CABG registry. So here you see that actually the outcome is even better than in the randomized CABG arm. Now if we look at the PCI registry, the outcome is 28.6%, but keep in mind these were patients that we didn't want to operate upon because they had a lot of comorbidities, and we thought that PCI was actually a better form of treatment in this patient population. Now to summarize this, I think that the 2-year syntax data show that surgery is still doing better than PCI. But it's mainly, again, driven by the higher repeat revascularization rate in the PCI arm. But there is a significant increase in myocardial infarctions compared to the 1-year results in PCI. So more myocardial infarction in the PCI population. But still there is a higher CVA rate, and that is where we as surgeons have to look at how we can try to decrease the CVA rate in surgery and to have a better outcome there, because the CVA is an adverse event that we want to avoid. The composite safety endpoints are similar compared to the 1 year. So the MACE rate at 2 year are not significantly different for patients with low versus intermediate baseline syntax score. It seems to be that, but keep in mind these are kind of subgroup analysis, and we have to be careful with the interpretation. But it's definitely looks like the highest syntax score patients are better off with CABG. Now if we look at the three vessel disease or left main disease patients, there seems to be a trend that in the left main disease patients, PCI is actually doing pretty well. Therefore, I think that if you have patients with this kind of disease and a high EUROS score, this patient might probably be better off with PCI. If you have a patient with a higher syntax score, it's definitely that surgery is the preferred option. But of course, what is important is that the syntax patients will be followed up to 5 years to draw the definite conclusions, and probably we will need another trial to look at the left main disease patients. And Patrick Reis will talk about that later during this session. Thank you for your attention.
Peter, thank you for that very clear, very concise and very elegant presentation. Just so that the audience know, what we had planned to do was give the 6 presentations and then hold discussion till the end so that we don't have unnecessary discussion before other presentations. So we'll next ask Dr. Michael Mack to talk about the risk of cerebrovascular accident in syntax, and he's going to put this into perspective.